Okay, welcome back. So routine investigation we usually offer to all the patient of during the antenatal care, but special investigation only for the high risk patient or where there is tendency of sudden complication or there is sudden when we anticipate certain problem in the fetus or in the mother. Okay, so first and second trimester aneuploidy screening. Okay, this includes ultrasound as well as serum markers like PAPE and beta HCG. Okay, in USC we tend to look for nuchal translucency. Okay. Nuchal translucency, nasal bone. Okay, so these are linked with the certain syndromic disorder like increased nuchal translucency in the Down syndrome or in Turner syndrome or patient with a congenital heart defect. Okay, nasal bone, absence of nasal bone can suggest Down syndrome. Okay, similarly, other includes double test, triple test, screening for Down syndrome, quadruple test, and metal serum alpha fetoprotein, especially neurotutive effect. Okay. Other special tests includes like diagnostic prenatal test for suspected chromosomal abnormality. Okay, like fluorine sampling, amniocentesis, chordosynthesis. Okay, these are the diagnostic tests. So if we detect any high risk patient during the screening, like double test or triple test or quadruple test, we offer the patient diagnostic prenatal test. Okay, glucose challenge test or OGTT. So ideally glucose challenge test, what we do here is a routine. Okay, and TSS, okay, thyroid stimulation hormone. This is also routine in our hospital. Okay, we do these tests routinely. Okay, so pH investigation, especially in the hypertensive cases, modified biophysical like yes CTG or non-stress test and amniotic fluid index AFI. Okay, non-stress test. So these are the special tests we commonly offer to the high risk patient. And ultrasound like 32 to 34, especially if we suspect the abnormal placentation. Okay, low-lying placenta or placenta previa. Similarly, ultrasound for weight and amniotic fluid volume if there is clinical suspicion of IUGR, oligo, or polyhydramnios. Okay, and umbilical artery Doppler, especially hypertensive disorder or IUGR. Okay, so these are the special prenatal tests. Okay, so especially if we suspect any abnormality in the fetus, so likely if we suspect some syndrome like Down syndrome, Pata, or Edward syndrome, in that case we offer patient triple test, quadruple test, or double test. Okay, or when there is obvious abnormality in the ultrasound, so suspected certain markers. There are certain markers. Okay, in the ultrasound like nuchal translucency, nasal bone. In such patient also we can offer the patient prenatal diagnostic test. Okay, so this is amniocentesis. We aspirate certain amount of the amniotic fluid and we send for cell culture. Okay, so send to the lab to look for any chromosomal abnormality. Okay, it also helps certain to test certain biochemical studies as well as enzyme studies. Okay, and chordosynthesis usually done around 20 weeks. Okay, so amniocentesis we can do around 15 to, so this can be done around 15 to 20 weeks. Okay, so chordosynthesis around 20 weeks. Okay, this is the chorionic villus sampling, and CVS it can be done around 11 to 14 weeks. Okay, so what are the methods for assessing the fetal health in high risk pregnancy? Okay, so we usually advise the patient to count daily fetal movements. Okay, fetal heart rate recordings like CTG, especially in the high risk cases, biophysical profile. Okay, which includes detail about the fetal movement. Okay, so it takes at least half an hour. Okay, so we look mainly for fetal movements, fetal breathing movement. Okay, amniotic fluid volume. Okay, so and fetal tone, and anesthesia is also included. Okay, that is non-stress test or CTG, and monitoring of the serial growth scan for monitoring of the fetal growth, umbilical artery Doppler, and biochemical test for assessing the lung maturity. Okay, so these tests usually we do not do nowadays. Okay, so commonly what we perform is umbilical artery Doppler, okay, serial growth scan, biophysical profile, especially modified biophysical profile. That means CTG as well as AFI. Okay, first AFI or NST and AFI, and we advise the patient for count the fetal movement. Okay, sorry. Okay, so now we are coming to the end. Okay, so let's discuss briefly about the management. So this is a general topic. So each and every headache patient usually we'll deal in separate lecture. Okay, so in general, how we manage the patient, always, especially the patient with bad obstetric history or certain medical disorder, ideally they should come for pre-conceptional counseling. So during discharge, okay, all the patients should be advised that she should come to the pre-conceptional counseling for next future pregnancy. Okay, so that we can optimize her condition beforehand. Okay, and apart from the routine antenatal care, this group of patients, they need special obstetric care in well equipped center. Okay, maybe she had a mishap in midwifery led unit, maybe in case of like sub health post or primary health care. So in such, if those high risk patients are identified beforehand, then we have to refer to the tertiary center or well equipped center. Okay, always every visit we try to screen for high risk patient. Okay, try to prevent, avoid, and correct the high risk factor as early as possible. So it depends upon the type of high risk. Okay, so management, specific management, it depends upon the type of high risk patient. Like if the patient has previous history of hypertensive disorder, let's say preeclampsia or eclampsia, so what are the intervention in current pregnancy? Yes, we tend to start a low dose aspirin, baby aspirin, okay, around 12 to 14 weeks of gestation. Okay, we tend to provide if the patient is deficient in calcium, we tend to give high dose calcium in this current visit. Okay, we tend to screen more often. We ask for more frequent visit. Okay, so every visit our blood pressure should be monitored, likely urine should be tested for proteinuria. Okay, serial growth scan. Okay, so that's the one example of high risk pregnancy, like hypertensive disorder. Okay, so that's why it depends upon the type of high risk, so how we manage the patient. Early identification in the first visit or booking visit. That's why booking visit is very, very important, because we try to take a detailed history of all the patient to make sure we identify any high risk factor. And this identification, okay, and the screening should not be confined to the first visit. Okay, every visit, even in subsequent visit, you try to screen. Okay, especially while doing examination or asking certain questions which where the proforma is not filled. Okay, assessment of the maternal and fetal well-being in subsequent visit. So always what we tend to do. Okay, according to the risk pregnancy, we tend to run some more tests. Timing and mode of delivery should be decided. So by around 36 weeks in general patient. Okay, but maybe as early as 32 or 28 weeks in case of high risk pregnancy. So if the patient is twin or triplet, as early as 28 weeks, we tend to decide the mode and timing of delivery. But if it's a low risk patient, relatively less risk, around 34 to 36 weeks. Okay, and neonatal care. Okay, so we liaise with the pediatrician for neonatal care. Okay, so this is all about the high risk pregnancy. So if there is any question, so I'm happy to answer. So basically, this is the general topic. Okay, so we are not dealing with the specific high risk patient. Okay, so it's a general topic, and most of the cases, most of the high risk patient will be dealt in separate lecture. Okay, but this is just our aim is to give just a general idea about high risk patient. Okay, so any queries?
No, sir.
Okay, thank you.